Probably one of the most difficult parts of my practice, and unfortunately it doesn't happen very often. It's always a very awkward situation, depending on the circumstances, but it's one of the more uncomfortable things to do, and generally don't like to talk about it, but I think it's a very important skill when you do need to do it, and especially for our junior colleagues, they would have had the experience of having to do it. So, hopefully this video will help them in the process.
Yeah, I think it's a very important topic, and it's one I'm very, very interested in. I've got some of my own views on it, so I'm very much looking forward to hearing what you've got to say.
Yeah, well, this is stimulated by a bulletin put out by my medical indemnity group, and they actually had an article on this topic, ending the doctor-patient relationships, and I thought it would fit in very well with our overall consultant survival skills course. So I'll just discuss around these three questions. So what are the reasons for the doctor-patient relationship breakdown? What are the obligations of our duty of care to our patients? And what is the correct approach for ending a doctor-patient relationship? And of course, there's many ways to skin a cat, and this is just one approach based on my experience and based around the bulletin that came out from my Medical Indemnity Association. So there's various reasons why the doctor-patient relationship breaks down. There can be a loss of mutual trust, and this can be the doctor not trusting the patient, and perhaps in terms of compliance or not being totally open with you regarding the history. That there may be, for instance, drug use involved, that there may be social issues, or that they may have an abusive spouse, and that can be male or female. That there may be problems with the patient becoming violent or aggressive. And I find some of the workers' compensation cases can generate a lot of emotional angst, especially if there's a legal process involved. Fortunately, I haven't had any patients physically attack me yet, although sometimes you do get the feeling that your physical body may be at risk. And luckily we have a slit lamp between us and the patient sometimes. I think that saved me a couple of times. There may be boundary issues, and there may be social issues. We always worry about sexual discrimination, and that can be a problem. There can be religious issues. I've had a patient, I remember, who had a burqa, and she didn't want to lift her veil for me to examine her eye, and that was a little bit of an issue. I've had a patient recently who had high pressures and narrow angles, and she refused for her eye to be touched. So we were able to do a non-contact tonometry, and we were able to get visual acuities and OCT scans and a visual field, but I couldn't physically touch her eye, so I couldn't do a Goldman applanation tonometry. I couldn't do a gonioscopy, and yeah, that's still an evolution, that doctor-patient relationship. I may not be able to fully give her the examination that I need to do and the appropriate management. There are patients who don't attend appointments, who actually just physically don't turn up for regular follow-up, and it's very hard to keep a good doctor-patient relationship if their management is suboptimal. This happens a lot in the public system, where people, for whatever reason, they either can't afford to attend or just have to work. There's economic issues as well as social issues there. Non-compliance of treatment recommendations, and it's frustrating for the doctor, particularly if you know the medication or the treatment you want to do, like surgery, is in the best interest of the patient, but for whatever reason that the patient doesn't want to take the medication, can't afford the medication, can't afford the surgery, or doesn't want the surgery, it's very difficult for the patient and doctor to actually have a good relationship. And sometimes perhaps another doctor's approach may be better. Not every patient you see you're going to get on well with. The majority you do, and you can have a good doctor-patient relationship, but it's inevitable that some patients just aren't compatible with your style of practice of medicine, and that's when the doctor-patient relationship is not ideal. So you can try different things, different approaches with different patients, and I suppose the more experienced you get, the better you get at doing it. And I think when you first meet a new patient, as soon as they walk in the door, sit down, that's the very start of the doctor-patient relationship, and often you get a feel in the first 5 minutes or even before on how things are going to pan out over the long term. And that's very much depends on, there's body language there. There's all sort of non-verbal cues that you can actually pick up on to see whether the doctor-patient relationship is going to be suitable for long-term management. So what are your thoughts on these issues, Pete?
Well, I think that's a very good introduction, and I think you've covered all the major points there. For me, I think the point that you've put first is the most important. I think loss of mutual trust, I think that is incredibly important. And I think in a long-term relationship where you are actually perhaps going to be operating on a patient or taking them through very difficult management decisions and potentially dangerous operations, it is absolutely essential that you have mutual trust. And without mutual trust, I think you're unwise really to continue the doctor-patient relationship. And I'm just trying to make one comment at the start of our discussion, which is the General Medical Council has put together some fantastic information over the last several years, and there's a really brilliant document called Working with Doctors, Working for Patients, and the section ending your professional relationship with a patient is particularly good. But I must say, whilst agreeing with absolutely everything that the General Medical Council recommends, I also have my own views on this, and I think in some ways the pendulum has swung a little bit too far in terms of working for patients, because I think we need to work for doctors as well. We need to help doctors deal with very difficult patients sometimes, and there needs to be a recognition that some patients are incredibly difficult to manage with, and it's stressful for the doctors, and the doctors need support. So I think the pendulum needs to be perhaps just a little bit more balanced, but certainly I think loss of mutual trust is a good starting point for the discussion.
Yeah, people get very defensive about this topic, and especially in this harsh medico-legal environment that we practice, people are just thinking, how do they avoid legal issues? And it takes away the human side of things, and as you say, for both the doctor and for the patient. So yeah, this is not a medico-legal talk. That this is I very much want to concentrate on the more human aspects of the.
Yeah, I think just like we could almost put this talk in context with two extremes at the start. I mean, you may have one patient who is absolutely obsessed with their appointments being on time to the nearest minute. They may well have obsessional compulsive personality disorder, they may be very busy, and they want their appointments to be scheduled to the minute. So you may have a clinician, probably a clinician a little bit like yourself and myself as professors, where we do a lot of emergency work, and a lot of very complex problems can present into our daily life unexpectedly and have to be dealt with. So at the outset of a relationship, part of the boundary management with someone with that personality characteristic would be to say, I respect the fact that you want to be seen precisely on time. I would love to be able to do that for you, but in fact the nature of my work means that I can't do that, and therefore I am not the best person to look after you, and I would make the following recommendations. And I think an amicable parting of the patient and the surgeon at the very earliest stage there would be in everybody's interest. At a more serious level, you may have a patient who is litigating a surgeon. And although the General Medical Council would say that just because someone is complaining against you or litigating you is not necessarily a reason to end the relationship, if that process involves loss of trust and you are not going to be able to function and make the decisions that you need to, it is your duty to involve other clinicians or indeed transfer the patient to somebody else. And you have to be very clear in your mind whether you're moving into a kind of defensive medical zone because you've been spooked by the patient. And again, I'd just say very strongly that I think the pendulum needs to move back to support doctors as well as patients. I realise that may not be something that everybody agrees with.
No, I hear where you're coming from, Peter. It just reminded me of a patient that I've had previously. He was waiting to be seen, and he'd been seen by all my clinical staff. He'd had fields and scans and everything he needed to. So it wasn't exactly he was doing nothing while he was waiting to see me. But he said to me from the outset, "You think your time is more valuable than my time." It's a bad way to start a new case, but yeah, I told him exactly what you're saying. We see complex cases, and we can't always calculate how much time we need to spend with each patient, and you get emergency patients where it takes longer, and often they've seen multiple ophthalmologists. So yeah, even though they book, say, 15-minute, maybe half an hour appointment, you're always going to need more time. And indeed, they may be complex issues for that particular patient, and they themselves will take up more time, but they don't seem to think about other people's time that they may be encroaching on. So it's kind of a very self-centered view of just from their perspective of their time. But yeah, if a patient is rude to any of my staff, and often it can be quite biased because they may be quite nice to me, but perhaps my staff will mention subsequently that they're very rude at the front desk. I don't tolerate that at all, and I will tell them, if you are rude to my staff, we can't continue to see you. And some of them actually don't come back. But yeah, I don't have any tolerance for people who are going to be rude and maybe very intimidating and can cause disturbance in the waiting room, that they can stir up other patients, that they may be quite damaging while they're actually in your clinic. This is taken from the section 3.13, Good Medical Practice, a Code of Conduct of Doctors in Australia, and this would be very much along the same lines as your GMC, I suspect. And they state that in some circumstances the relationship between the doctor and patient may become ineffective or compromised, and you may need to end it. Good medical practice involves ensuring the patient is adequately informed of your decision and facilitating arrangements for the continuing care of the patient, including passing on relevant clinical information. So yeah, unfortunately, the doctor-patient relationship that does break down, and as I was saying, you can't get on with every patient that you see, but yeah, fortunately, the majority of patients are very good and respect that doctor-patient relationship. But yeah, you do get the occasional patient that you do need to have some process to end the doctor-patient relationship.
Yes, I think the GMC very much recognise that there can sometimes be a breakdown in the relationship, and the GMC, again, much like your slide, offers examples of when a relationship may need to be terminated, and then goes on to describe what you should do before you end a relationship, and gives advice to ensure that however the dynamic of the relationship between doctor and patient, your actions are not seen to be punitive. So, for example, if a patient makes a valid complaint about you, then the punitive response of trying to get rid of that patient would not be appropriate.
Okay. Yeah, well, I suppose that we're focusing mostly in this talk on how to actually end the doctor-patient relationship. Certainly we could have a talk sometime on how to prevent that situation from arising, but yeah, this is focus on that ending process.
Yes, and I mean, just out of interest, the section that actually starts before you end the relationship, it's called, does offer some good advice. Actually, it says before you end the professional relationship with the patient, you should A, warn the patient that you're considering ending the relationship, B, do what you can to restore the professional relationship, C, explore alternatives to ending the professional relationship, and D, discuss the situation with an experienced colleague or your employer or contracting body. And in the process of terminating your relationship, it suggests that you must be satisfied that your reason for wanting to end the relationship is fair and does not discriminate against the patient. So, as you say, there's some actually good discussion to be had about how you can possibly save a relationship. But as you say, this talk assumes that you've gone past that point, doesn't it?
Yeah, just briefly on that. Yeah, if you do feel that the relationship is not heading where you want it to go, if you can head it off early and prevent further breakdowns, patients do come to their senses sometimes and actually realise their behaviour is not conducive to the doctor-patient relationship and can turn a new leaf. And sometimes your doctor-patient relationship becomes stronger because you've gotten over that hurdle and you can move on. So yeah, it can go the other way if you get it early enough.
I think you're absolutely right, and I think addressing difficulties before they escalate is a great way of actually strengthening your relationship with your patient, and sometimes just sitting down and saying, look, things aren't working out. Here's your point of view. Let me tell you my point of view as well. And, if you do it in a non-judgmental and non-confrontational way, I think you're absolutely right, Graham. You can end up with a patient who has a much stronger relationship with you and much more mutual respect.